Can you introduce yourself and talk us about your work?
My name is Robert SCHOEVERS. I'm a psychiatrist and a professor of psychiatry and the head of academic psychiatry department in the north of the Netherlands. My main research topic is depression, and clinically we see, of course, many patients with treatment-resistant disorders across the diagnostic spectrum. So we're always interested in novel treatments or in improving already existing treatments. And that's how I came across ketamine around 2013. We did a number of pilot studies with generic oral esketamine, so the variety that was already on the market, which in Europe is the dominant isomer, right? So in the US it's the other way around. We did a number of pilot treatments for people in off-label compassionate use for people who were really severely ill. And we found that some of them were impressively improving. So then we performed a number of clinical trials. And we also participated in the worldwide psilocybin, the international psilocybin study initiated by Imperial and Compass. And we are now in the process of setting up new projects with new compounds, also broadening the indications, so not only depression. And what I found and find fascinating is that, for example, if you look at how we started prescribing ketamine, then that was as a purely pharmacological drug. So you give the patient the medication, you put the patient in a quiet room, the nurse will come and take your blood pressure, and then we hope it will have a rapid, it will have for this patient a predicted fantastic rapid effect. And it is only after we started doing qualitative research, so openly asking people, looking backward on these experiences under the influence of ketamine. So ketamine is not a one-time treatment as other psychedelics, one or a few, but we do it repeatedly, twice per week for 6 weeks. And then if the response is good, we also continue, we build up the dose. And we found that despite the fact that we are very patient-oriented and we try to do these things with a lot of care, we had totally missed the fact that these patients were, not everybody, but some of them were really anxious of losing control, of letting go. And we had told them about adverse effects, passing feelings that you may have, or funny experiences, or even hallucinatory or dissociative, but we hadn't really prepared them on how to deal with that. And for some, this has really been a very challenging and not a positive experience, and some also stopped the treatment. So it was a bit a shameful, confronting finding, but it was also very, I'm very glad that one of our PhD students did this, because that's how we learned that also ketamine is not just any pharmacological agent. It needs to be applied with utmost care in a setting that is akin to what we do in the classic psychedelic treatments. So we prepare patients, we do grounding experiences, we have a therapist that I know who is supporting them during the sessions. It can also be with family members who are also included into the training. People can have music scores, the room is quiet, everything that you would do also with classic psychedelic treatments. And the funny thing is that this is not done in the ketamine field. I presented this findings at the Oxford Ketamine conference, and I got a lot of reactions, and many people were sort of, as we had been, wondering whether we had missed something. So we now, and what I find very interesting and also very plausible, is that as a team we are also psychotherapeutically oriented, but we now make this into a more holistic approach, even though we treat hardcore, severe, treatment-resistant depression. And we have patients telling us that as these sessions go on, they discover new elements of their history or their trauma or things that they were very much ashamed of or sort of try to keep away from their conscience. So it's in a way, it's basic psychoanalytic models that you sort of use to conceptualize the psychological mechanisms. So they slowly make steps in a psychological process that for them is very meaningful and that goes far beyond the direct effects on mood, even though the effects on mood, of course, are necessary to be able to have a psychotherapeutic process.
How do you see the future potential of the therapeutic use of ketamine?
I think ketamine is quite far in that respect. At the same time, there's many things we don't know. It looks more and more as if, especially in severe... So the people we treat, they have a mean episode length of depression of 5 years. They have had 9 different medications. They have had ECT. They've had psychotherapy. It's a bit naive to think that one treatment phase would take all of that away. Nevertheless, we have about 200 patients in a national program now who are coping quite well, and they use ketamine at home once a week, once per 2 weeks, and we taper it down. We are in contact with all of them, and we sort of working towards a model where they have confidence that there is this compound that will help them if depression starts to increase again. And at the same time, they have other therapies. So also in the short run, there's this window of opportunity, window of plasticity that everybody talks about. I think that's a valid model to look at things. But also in the long run, recovery is never only in the compound. You have to sort of redress your whole way of life. Depression affects so many aspects of life, and as does any severe mental disorder, that you need to take into account that you focus on all of those aspects in order to possibly prevent relapse and improve your quality of life. So it's much more of a continued treatment than we are sometimes led to believe. And then, of course, there's challenges, because ketamine is also a party drug. It can be used for malicious purposes. If all of these compounds are put into the hands of people who are not very considerate or not so well trained or not realizing also the hazardous side of them, then I think that will be very bad, not only for patients, but also for the whole field.
How can you mitigate these risks, especially among the patients? I'm sure that many people are concerned about it.
Yeah, well, I'm now talking about ketamine, but also with the whole range of psychedelics that's sort of upcoming. I think we should realize that the trials, as they are available at this point, have often not been done in the garden variety patient with a severe mental illness. So these are patients often who self-select, who often have some prior experience with psychedelic recreational use, usually higher education. They are able to verbalize the experience, whereas many patients with severe mental disorder, they are less well educated. Early life adversity, early life trauma is extremely prevalent everywhere, but especially in people with mental disorder. And having an overwhelming experience in which you are encouraged to let go control and live through this can be extremely anxiety provoking, and we don't know at this point who is going to benefit from this experience and who is not. So the fact that maybe 0.001% of the whole spectrum of people with a certain diagnosis have now been treated with beneficial effects doesn't tell us that all of the rest are the same kind of patients. So we really have a lot of work ahead of us to see whether what the balance is between harm and benefit.
So there is a risk that psychedelic therapies will remain a privilege of the white middle class, upper middle class. Do you agree with this?
Yes, that's a risk, and it could be that we don't know these things. So we should acknowledge that we don't know them, and we should do the trials that are needed to find out if they can also be of benefit to the most severe patients with the poorest prognosis. Because, of course, if it's beneficial for other patients, that's great. As a clinician, my largest concern is with the people who have the poorest prognosis, and maybe, and that's raising the bar, right? But I think we need to raise the bar just to see where it's still beneficial and where it's maybe not. David Yaden had a great talk on the hype. I always tell people psychedelics are going to crash, definitely. And I fully agree with him. They should, because we are never going to be able to sort of prove what very enthusiastic people think or write about and everything. The severe mental disorders are too complex. On the other hand, by doing proper research with well-trained professionals in a responsible way, in safe circumstances, my hope is that will still lead to valuable novel treatments.